Okay, there we go. Hello, everyone, and welcome to today's webinar, The Path Forward, Recentering Our Work in AOD Prevention Post-COVID, Part 2. My name is Orlando Cooper, one of the graduate assistants at IHEC, and I'll be your moderator. I'm assisting Madison, the Assistant Director for the Illinois Higher Education Center for Alcohol, Other Drug, and Violent Prevention, and we are very excited to be hosting today's event. As I said on day one, that if you're asking for CHES credit, please make sure that I have your CHES number. And if I do not, please email me. My email is attached to my screen right here. Other than that, I will pass the presentation along to Joan Masters. So the floor is all yours, Joan.
Thank you, Orlando. So for those of you who were maybe not with us or missed our introduction on Monday, my name is Joan Masters. I'm the project director for Missouri Partners in Prevention, which is a statewide coalition similar to IHEC in Illinois of 24 colleges and universities in our state. And we're funded by the Department of Transportation, the Department of Mental Health, and the Department of Health and Senior Services to create evidence-based programs, equitable and accessible programming for all of our campuses across the state. So I want to just do a few housekeeping details before I get started. There are multiple times in this session where I'll ask you to put things in the chat, or if you feel comfortable to come off mute. So just be prepared for that, I would love to have some engagement in this presentation. This is a presentation where I'm going to be looking at sort of what are our evidence-based strategies moving forward. How do we use the SPIF to recenter ourselves on AOD prevention post-COVID-19? So really engagement in terms of giving me feedback about what you want to know more about, what questions you have, where you're at on your campus with some of these things is going to be very, very important. And without it, it's going to be just not as rich of a presentation as it could be without engagement. So just a note about that. Also, for those of you who did not join us earlier this week, my colleagues from Partners in Prevention, Margot Lightshoe and Kaylee Greenwood, did a fantastic job of setting out some information that we have gathered in some work that we do in Missouri Partners in Prevention about the effect that COVID-19 has had on our students and their AOD work, or their AOD experiences and behavior. So I'm not going to spend a considerable amount of time at all reviewing that data because that was in the presentation. I know you probably have access to the recording and our slides through Orlando at IHEC. But what I am going to be doing today is pulling back a little bit and starting where Margot left off, where she, at the end of her presentation, where she was talking about the social determinants of health and the need to approach our work with cultural humility or cultural competence, that part of the reason why we do that is because we implement what's called the strategic prevention framework, or the way in which we plan our prevention to address substance misuse or really any sort of problematic health behavior for campuses, is that we use a planning process like the SPIF. But more importantly, it is just incredibly, it is sort of a center point of our work to know that we are listening to the voices of the folks that we are serving. And we can't do that without a lens towards cultural humility and sustainability as well. So we're going to be going through the SPIF planning model and talking about what this means now that we are working our way out of COVID-19, hopefully, or coming to a place where we're living with it, where it's sustainable on our campuses. I will say that when we created this title, it was 6 or 7 months ago. Omicron was not here. We were feeling like we might have a little bit of a breather from the everyday grip of COVID-19, and that's certainly not where our campuses are. I think in our 4 days just this week with our work with Missouri Partners in Prevention, I've talked to 3 or 4 colleagues that have broken down about the state of campuses right now and the extra work that they're doing and the effect of COVID-19. And I recognize that. So I don't want to be flippant and say, okay, let's get to work. Let's really get in there and address substance abuse prevention because COVID is over, because I don't believe that to be true. But what I do believe is that we have learned things during COVID-19. We have practiced levels of engagement with colleagues on the addressing of COVID-19 that we can carry forward into our substance misuse prevention. Additionally, students have changed. We don't really have a single student on our campuses that probably hasn't had their education affected dramatically in the last 3 or 4 years. And so it's important for us to note that some of the things that we were doing in 2019 or 2020, we can't just pick up those plans and expect to engage with them and do them in the exact same way now that we've lived through COVID. Once we know more, we do better. And so it's important to note that. So I want to just share our learning objectives for today. First is just to talk about the fundamentals of the public health approach. The fact that doing substance misuse prevention is science-based, period. And stop. It is not something that we do for fun. It is not something we do because there's an incredible amount of payoff in it sometimes. It is very hard work, but implementing the public health approach with fidelity, making sure that we're doing things that make sense for our campuses, make sense for our communities, and have that backing of science behind them is key moving forward. So we're going to talk about that in this strategic prevention framework. We're going to talk about the unique substance misuse prevention challenges that our higher education institutions have. We can't move forward until we note that some of the things that we've experienced in the past 2 years with COVID-19 that we've learned about systems of higher education, both the strengths and the weaknesses of our institutions. We can't pretend that information away. We know now about how our communities either value or devalue health. And so we need to move forward with that new knowledge in terms of how we work together. And we then hope that you are ready to then implement evidence-based strategies or implement the SPIF in at least some way moving forward. So this is my first sort of interactive piece. I just want to know what questions you have, what things you're hoping to learn from today, why you came here. If you came here for the CEUs, that's totally good, all good. But if you have a question or you're hoping to learn more about something in particular, please put that in the chat and I will watch that and make sure that if I can't incorporate it, I'll at least provide some resources at the end. But I'd love to hear from you a little bit more about what brought you here today, and what you would like to learn. I'm going to start here with just noting some base level assumptions that I am making as a presenter and that are informed by my work in substance misuse prevention. So this is not necessarily the evidence-based part of the presentation, but it is the experience part, if you will. And I would love for anyone to put in the chat things that you have found to be true in your work moving forward. But here are my base level assumptions and things I want to share with you. First of all, substance misuse prevention, the prevention of students misusing alcohol, other drugs such as nicotine and cannabis or other substances is hard. It is not easy. It is something that takes continual work and often doesn't have the payoff of necessarily seeing the end result. We don't see the things that we prevent. We have no idea. And so it is hard. Secondarily, my colleague of a very long time ago, Pat Fabiano from Washington State, once coined the term or said the euphemism that substance use prevention, misuse prevention takes 100 cups of coffee. It takes us time to cultivate relationships with each other. It takes the ability to make those individual relationships with colleagues that if people expect to sit in their office and only watch webinars such as this and not get out and have those relationships with people to truly address substance misuse, things are never going to change. And sometimes hard conversations happen over coffee. And I'm certainly not saying that you have to drink coffee. It could be a walk around campus or a quick Zoom up meeting, but I value so much. I have about 5 female colleagues in prevention or in healthcare where we meet for a half an hour coffee over Zoom once a month just to talk about life and what we're doing. And it always reframes how I'm thinking about my world. And sometimes we then can gather projects together and start to work on them. But really, it's those 100 meetups with people where we really build our work. Substance misuse prevention is science-based, period. This is something that is based on a public health approach. It is something that is not necessarily like a student affairs, student activity based work. Certainly, we have so many colleagues in the state that work in student activities or in res life or other student affairs positions that do fantastic prevention, but they have to do extra training to understand what it means to implement the public health approach, to implement the SPIF. And so we're glad you're here today to learn about this or to think about your work a little bit different. Substance misuse prevention is not just planning things that students like. It's sometimes challenging their expectations. It's sometimes rewriting policy, holding students accountable through policy, prevention of student attrition to retention, student death, etc., sometimes means having hard conversations with students and or maybe your boss or your administrator. I've been in multiple conversations with others and their administrators or my own administrators where I'm not necessarily giving great news. I'm sharing survey data or assessment data where I'm telling them that the binge drinking rate is higher than I would want to see it for this particular campus, or that it's this amount of students on campus that come from this particular identity or intersectional identity that I'm truly worried about on campus. And sometimes those conversations are hard. Substance misuse prevention requires challenging our own beliefs about our health, our rights, and how our behavior affects others. And the reason why I say that is that sometimes we might have our own thought process about, how people should be able to be accountable to our own selves and not necessarily need the university to enact laws or policies or things that hold students accountable. I've encountered a lot of people that have said we should have no policy accountability on campus for students because if they drop out of school, then that's on us. Well, I encourage all of us to challenge those beliefs because I think that those beliefs are centered in sort of a black and white model, as opposed to thinking about the fact that we're helping that student be more successful to stay on campus, that it's okay to do things that are hard in prevention. Second to last, substance misuse and prevention in higher education, and this is the one I feel the most strongly about, is that sometimes we have to challenge tradition, misogyny, idolized behavior, memories of the good old days, corporate influence, particularly. I live in the state of Missouri, and we have a fairly significant alcohol lobby in our state, and systems of oppression as well. If we think about some of the at-risk behaviors that happen, particularly in our fraternity and sorority communities or within our athletics, we have to think about the fact that some of those things are rooted in very backdated systems of oppression in terms of who was let into those organizations, why those students are gathering together, et cetera. And also, substance misuse prevention is a shared responsibility. This is not your responsibility as a substance abuse prevention person, or singularly your responsibility as someone that has substance use prevention tied to their job. It should be something that's shared by all members of our campus community. We're going to look a little bit at just the foundation of our work first, and the public health approach and substance misuse prevention. Just wanting to look into the chat. So we're going to talk a lot, Sarah, thank you, about how to create or cultivate that shared responsibility on campus. And how do you teach that marijuana consumption can have a negative effect on the body, just like alcohol and tobacco? I'm not sure that we'll necessarily get to that particular point, but I can go back to that and see if I can circle back at the end. So let's see if there's anyone else. Okay, so we have a lot of questions or thoughts about cannabis, so I'll try and weave that in a little bit. Okay, so in Partners in Prevention, we shared this on Monday as well. We believe prevention should be balanced, comprehensive, evidence-informed, evaluated, and a shared responsibility. So we talked about that shared responsibility on the last slide. When something is evidence-informed and evaluated, it means that we are picking strategies that have evidence that prove that they work. However, there's a big caveat to that. We also need to make sure that we're implementing things that are culturally appropriate for our campus. And so if there is a lot of evidence that this particular strategy that you're choosing works, but it hasn't actually been evaluated on the students that are like your students on campus. I think about a lot of the things that we have in our college aim, which is our kind of go-to reference point for picking out, strategies that work well for our campus. If you read through some of the limitations of the studies listed in there, a lot of the studies have not been done with a sizable amount of students of color, or have not looked at the effect of that program on students who identify as LGBTQIA+, or students who are gender nonconforming. And so it's important for us to always keep in mind that we want to implement evidence-informed approaches, but we need to evaluate them to make sure that they're truly working on campus. And then we need to think about things being balanced and comprehensive. So balanced means that we're not just educating incoming freshmen, or we're not just doing things in a first year experience class, that we are providing education for a student throughout their lifetime. I think about this a lot when I think about the issue of nicotine and vaping, where students are maybe come to campus and they either start vaping or they've been vaping, and we can talk to them about quitting and reasons for quitting and resources for quitting. But when students on our campuses get to be juniors and seniors and they start looking for jobs, as particularly full-time jobs, where maybe they don't employ you, or they give you a higher insurance premium if you smoke or use nicotine, or they don't give breaks for people to use nicotine products, students start to wonder if they should quit. And so there are other things that we can do, maybe different than what we shared with them as they were freshmen, but partnerships with the Career Center, partnerships with the folks that send our students out for internships and practica and stuff like that, that they could learn about the resources about quitting nicotine either on campus or in the community. That's going to mean something different to that student than it would like as a junior or senior looking for a job, maybe than the place that they were at as a first year student, assuming it's a four-year university. And also it should be comprehensive. And so the students who misuse tobacco on your campus or nicotine are not, they're not separate from the students that misuse cannabis or the students that misuse alcohol. There's a good amount of poly drug use among students, are what we call co-use, which means that students are using alcohol and maybe a different time they're using cannabis, but they're using as part of their as their menu of things that they are experimenting with in college. And we can't necessarily address alcohol by and not address things like intersectionally, like sexual assault or anxiety. To say a little bit more about cannabis, I think that what we are seeing on a lot of college campuses is that students are medicating with cannabis and saying, well, see, I'm anxious and I use cannabis, and therefore it must have been the cannabis that worked. It was the medicine that I needed to take. In Missouri, we are a medical marijuana state. We do not have recreational marijuana, but most students actually don't have a medical card. They just self-medicate. They have not actually seen anyone for a prescription. So, but then they say, I want to quit cannabis. And then they get very anxious. They have trouble sleeping. And they say, oh, see, it was the marijuana. I needed it all along. And they fail to recognize what some of the key indicators are related to cannabis on campus and what it means to withdraw from cannabis. That cannabis withdrawal comes with lack of being able to sleep. It comes with anxiety. It comes with maybe jitteriness or something that, is like a withdrawal from that substance. I will note that for those who are interested more in cannabis, one of my colleagues from PIP can put our training site in the chat. We have a 5-part series on cannabis that we're happy to share with anyone. You just need to register for it and it'll send you the recorded links. And one of the presentations is for Jason Kilmer, and his colleague who created what's called the iChamp program at the University of Washington. And both of our colleagues go through that program, talk a lot about the reasons why students use cannabis and how to talk with students about cannabis. So I highly recommend that training, especially if I don't get a chance to talk about it today. So if you scroll down under the professional trainings and you put your information in there, basically as soon as you register, you'll get access to that training. So what do we mean by prevention? And what am I going to focus on today? So we mean that we want to stop problems from occurring and reduce the risk factors and increase the protective factors that keep that, that behavior from happening. We want to change the underlying conditions in a population that lead to the problem. We do a lot of work for students in recovery. We do a lot of work supporting the needs of our counseling centers who provide response and treatment and early intervention. But for the purposes today, we're really talking about substance misuse prevention. And so I'm going to focus on that. For those of you who have never seen this graphic, it's truly one of my favorite, and when I keep this in mind when I work with a campus, it really, really helps. When we think about the work that we need to do in prevention, we often, I think, feel pulled in many different directions. Oh no, we need to have, like, what if students are get in trouble with marijuana? What do we have there? What is our prevention? What is our, what are we doing to have a policy about this, et cetera. So what we're going to be talking about today specifically is prevention. So if you look in the upper right-hand corner of this graphic, we are in prevention, fixing the bridge and keeping people from falling in. We're not saying that people didn't fall into that water well upstream because of another event in their life or maybe previous use while in high school, et cetera. But when we can fix the reason why they're falling into the water, we don't need to pull them out or give them a life preserver later on, which ultimately actually makes them at risk for more opportunities to fall into the water at other points in time. But if we can fix that bridge up in the upper right-hand corner, we are doing things in our communities that help us create a positive health environment. I apologize. I have a coworker that was not happy. I apologize. So what I mean by the public health approach is that we define what the problem is. We ask, what is the cause of that problem? Sometimes people call it a causal factor. And we determine what works to address that problem and for whom. That different things are going to work for different populations. We work with a lot of two-year schools and community colleges, and what works for them and their students is going to be different than what works for our four-year universities. And then how are you going to go about doing it? And so you'll see this planning process going from problem to response here in the next slide when we look at the SPIF. So for those of you who are unfamiliar with the SPIF, and it might be helpful just to put in the chat, like, I understand SPIF and I know it all the time. This is new to me. Please tell me more. This presentation will talk a lot about this process, but I just want to note that if you are not using the SPIF in prevention, you probably have used the SPIF in some form at some point in your life. So Margot and I were talking yesterday, and we were talking about, like, if you have to purchase a new vehicle, you probably are thinking about what cars or vehicles are out there that I might want. How much money do I have? You might read some safety ratings, and you might look at some of the features. That's all assessment. That's all gathering information. You might evaluate what you liked about your last vehicle. But likely you don't get to the place of implementing or buying that vehicle without at least thinking about what information you have in evaluation and assessment, and then asking yourself, how much do I have to spend and when do I need this vehicle? That's capacity. Capacity is identifying what our resources and our readiness are. I might want a vehicle that costs $40,000, but I have $15,000 or I have $5,000. And so while my assessment might have shown me that this vehicle is a certain safety rating, et cetera, and I like that, truly when it comes down to is, what do I have the capacity to do? I think about this model a little bit every time I cook dinner for my family. Like, what is in my cupboard? What do I have available to me? What do I know my family likes? I put it together, I plan, and then I implement it. We use the SPIF literally every day in our lives, and we just don't even think about it. And so I encourage you to think about this as we move forward. We're going to go back a little bit and talk about higher education and some of the things that we are seeing on higher education campuses and what makes some of this work inherently more difficult. But again, I want to bring us back to the fact that we're going to talk about the SPIF and talk about moving from assessment through evaluation, because that is really where we need to be post-COVID. Whenever we get to that post-COVID time, or that time where we feel like we can take a breath and we can move forward with our substance misuse prevention, I hope that by attending our presentations over the last couple of days, that you will think about pulling out the SPIF and starting to assess and pull together what information you have, and really thinking about your capacity. Capacity for campuses has changed dramatically over the last 2 years. And so we'll talk about that a little bit more. So what I want to talk a little bit about the problems and related behaviors that we have on college campuses. I know we have some folks that aren't necessarily in higher education on this call. So I just want to note the fact that the work that we do in substance misuse prevention in higher education is inherently blurred because of some of these unique factors. A lot of students, not all, but a lot of students have already started using before they have gotten to campus. So in Missouri, we have about 80% of our students are drinkers before they ever set foot on our college campuses. So the idea of using a just say no approach in higher education is out the window because they've already said yes. But at the very same time, we want to tell administrators that we want to set the stage for them and be able to let them know that that these problems are happening on our campus. We can't assume that they're non-users before they set foot on our campus. But we also don't want to necessarily tell students that everybody is doing it, because that will set a social norm that will expect people to, or people might expect to use more or kind of compete with each other. At the same time, as students have already started using, most students are using fairly moderately, that it's very much like a bell curve. And for the most part, the students in the middle, what we call the movable middle in the prevention work that we do in Missouri, are the students that are going to respond to the prevention work that we do. They haven't started using that much, or when they use, they're fairly moderate. They might have 1 or 2 drinks. They need to be given information about staying safe when they do, protective factor information, et cetera. For the most part, I think it's really the same with cannabis, although we have less students obviously using cannabis or nicotine overall than students who are using alcohol. But we need to work with that norm a little bit and let students know that while you might see that or think that most students are using, the students who are using probably are using fairly moderately and safely, or not at all. College has for a very, very long time been a time of experimentation. In fact, higher education, back to its very core of the building of higher education systems in the US, was an experiment. And so it's important to note that there's some natural, if we're assuming a 18 to 24-year-old college student, there's some natural parts of experimentation that is just part of the biology of a person that age. Additionally, we work with the adolescent brain. If we are assuming an 18 to 24-year-old college student, we know the adolescent brain isn't fully developed into the adult brain until the mid-20s. And so while the drinking age is 21, the age to use cannabis might be around that time. The age to buy nicotine in our state is 21, but the age to use it is 18. They are using those substances and making decisions with a brain that hasn't quite gotten to its full level of understanding of processing maybe risk and reward, or the risk factors that they have and why they should maybe make different decisions. And so brain science really comes into a lot of the work that we do. It's also, I think, very difficult when we work with campuses that you have a half of a group that these substances are potentially legal for, especially alcohol, and then another half that they're not. And students are coming on campus with varying laws from the home state that they come in on cannabis. So if you think about your nicotine or tobacco use purchase laws, We have a campus in the state of Missouri that actually caps the number of students in their incoming class every year from the state of Missouri, which means they get a very diverse group of students coming from all 50 states and many international locations. For the most part, those students have no idea what Missouri state laws are on cannabis or nicotine. And so they get here, and if that campus does not do any sort of education about what the state laws are or what the expectations are about using cannabis on campus, those students not only are are making decisions without all of the facts, they might just be unwittingly breaking the law or the policy. And so I think that we need to note that, especially with some of the questions earlier about students not noting that cannabis is maybe harmful to them, is that they might come by that somewhat naturally based on the state that they're from and what information they were brought up with. For some students in places like Washington and California and even Michigan, for the most of their formative lives, cannabis has been legal. And so if they then move to a place like Iowa or Missouri or Oklahoma or Kansas, where those laws are different, that's going to be very kind of a culture shock for them. And lastly, our work has to be data driven, which for a lot of people is sort of the place where the work dies, because we need to have survey data. We need to look at our data from our conduct office, et cetera. And that's difficult sometimes to get. That's a difficult partnership to make on campus. It's sometimes a difficult sell with administrators to ask if we can start asking questions of students about whether or not that the students are using alcohol, using cannabis, how it's affecting their academic life, et cetera. And so that does put us into kind of a trick box. We have other prevention challenges in higher education. Higher education is built on functional silos. I talked to a campus just this morning in our state that said, well, I'm not allowed to talk about alcohol and other drugs because I'm the violence prevention person, and I am not allowed to talk about that at all. And I would assume that the alcohol and other drug educator would say the same thing about violence prevention. And ultimately, that's really just harmful to the student. When campuses make the decision to organize themselves in functional silos, this is just my opinion, but that is it's really the way in which we show our our lack of focus to what's best for the student and our focus on what seems to be best for the university. And it comes from really a place of privilege. For those of you that are from, say, two-year campuses, small community colleges or small campuses, you don't have the benefit or of being in functional silos. You do all of the work in one person. And so we see a lot of these functional silos in places where our campuses are larger and we're not connecting on the greater issues of just students are being harmed in a lot of ways. They're being harmed through their substance misuse, through their violence, experience of violence in their interpersonal lives, and they're also being harmed by not being able to have resources on sexual health or mental health. Colleagues from different backgrounds and educational skill sets also is somewhat of a challenge. While I love getting together with a coalition and thinking about what our strengths are, sometimes we don't often all have the background in public health, or we don't all have a focus or a dedication to doing this planning model that we're going to talk about with the SPIF. We saw that play out recently in some work we're doing in Missouri, where we were switching from one program to another, and we really took our time to think about what is the best need for campuses, and really design something that works best. We started with assessment and capacity building. Well, those campuses, they wanted something to see right now, and they wanted to be able to implement it right now. And you don't necessarily get that when you implement a planning approach. We also focus our efforts sometimes solely at changing the individual, which does not create change overall. We think a lot about changing the student, and their behavior, but we don't think about changing the focus of our campus. We don't think about those things that are inherent in our campus systems that allow us to, that allow our students maybe to make some unhealthy choices. For instance, campuses that have head shops or other cannabis retailers within walking distance to campus. While we might not necessarily be able to address that, we have to own the fact that that level of accessibility of a substance that impairs is going to create problems for our students. And so that's not necessarily the student's problem that the head shop is right across the street, or the bar and restaurant community is within walking distance to campus, or that the bars and restaurants have promotions and specials that encourage students to drink more. That is our environment, and that is the community that we have, and we have to take responsibility for that. Oftentimes we believe it's someone else's job. We think that it is something that, not it. How many times have we been in meetings with folks that said, oh, I'm going to just stay in my lane? Well, prevention is not really a lane kind of thing. To do good prevention, we might want to stay in our lanes, but we all have to be on the same highway moving forward. And so while it's okay to have our individual contributions to the prevention work that we do, we have to note that we are all in this together. Our campuses also do a lot of waiting until it's a problem. We'll just see if there is an issue down the road, or trivializing the problem. Kids will be kids. This is how it's always been. No problem there. And unfortunately, it only takes one student death or one student to experience assault or a suicide on campus of a student that causes our campus then to suddenly be focused on planning. And crisis planning, or planning in a crisis, is never necessarily the time that we want, what we want to be doing. We want to be planning for a crisis or for eventual problems, but we don't want to be planning inside of it. So we'll start just a little bit with a question. So I'll look to the chat a little bit, but to think about, how frequently do you work with data daily? Do you look at data on substance abuse or misuse? Do you look at well-being data? Do you interact with it? And how often? Is it every day, occasionally, rarely? We don't have any data. And how comfortable do you feel working with that? Like, is it something that you don't really want to look at because it's overwhelming? So as we move into this first section of the SPIF and we look at assessment a little bit more, I'd love to know sort of where we're at with assessment, so I know things to focus on. Just waiting for a few more chat comments to come in. That's awesome that you love looking at data. We call ourselves data nerds in Missouri Partners in Prevention. It's really exciting to look at it. Sometimes it's more exciting to look at other people's data. Awesome. Not a fan. Daily. Great. Perfect. We're all in different places. I would say that there are people who love data and don't look at it daily. And then there are people who look at it daily and really hate it. So these two don't have to be mutually exclusive, that you look at it every day and you're very comfortable and you really love it. So it's important to, again, continue to look at the data that we have access to. So when we ask ourselves where we're at in the assessment data that we have for our campus, we need to determine what to assess. So if you are not assessing the nature and extent of substance misuse on your campus, you need to be doing so. And you could do that through things like the National College Health Assessment, the Healthy Minds Study. If you're a member of IHEC, I know they do the core. In Missouri, we do the MOCB, which is the Missouri Assessment of Collegiate Health Behaviors. There's a lot of statewide coalitions that offer some sort of assessment for campuses to use. You could also be thinking about ways in which you get this information as proxy. You look at, say, Residence Life might have their data on the number of students that are being held responsible for violating the alcohol policy. You might have information from your student health center about the number of students who reported that they were that they had alcohol involved in some sort of accident that they're coming to receive support for. And also in our assessment isn't just about the data of the substance use. It's about the risk and protective factors of our students. It's about how many students have a family member that has a substance abuse concern. That tells us a lot about the risks of our students as they are matriculating through college. It also is about how many students have not used before they've come to campus. So holding off until you're 18 or 19 years old to use substances is a protective factor against longer term substance problems as an adult. And so it's important to assess all of those things. And most of the major studies or the surveys that you can find do that. But again, if you can't do a survey, that's totally fine. You could start with things like looking at what funding you have available for prevention in each of the areas. How many people have substance misuse work in their job on campus? That's all data that you can collect. So the questions you're going to ask yourself when you're in the assessment piece of the SPIF, especially as you're working out of COVID, is what are the problems now? We probably have data pre-COVID. I know Kaylee on Monday shared a lot of information about how substance use really changed during the pandemic of our students, at least in Missouri. But you're going to want to ask yourself, what are our problems now? Are we looking at this? How do we need to look at this differently? How often are those problems occurring for our students? And where are they occurring? Are they occurring on campus? Kaylee shared some great data about how students had more access to their parents' medicine cabinets, to their parents giving them alcohol. They didn't necessarily drink more or use more prescription medication without a prescription, but they did have more access to it. Those are all questions we need to ask, and we need to reevaluate post-COVID. If you don't have a plan yet for doing some sort of survey post-COVID or as we're leaving COVID about substance misuse with students, I do suggest that as a next step. I think it's also very important, and Margot touched on this in her work, talking about the social determinants of health and how we have to look at our students and their identities intersectionally, is that what populations on our campus are most affected by these misuse behaviors. I think it's very easy to default to the students who are making the loudest bang about some of these things. We talk with students maybe in the counseling center about their cannabis use, or we have a lot of problems, say, with athletes or students in fraternity and sorority life. But how are these things on campus affecting our students of color? How are they affecting our students who are gender nonconforming or LGBTQIA+? We need to be asking those questions, because those are the identities of students that often that aren't focused on in a lot of our data. And we need to start asking those questions, those demographic questions on our surveys, so that we can begin to pull out what subpopulations are experiencing the most harm, either from their behavior or someone else's behavior. And then most importantly, what are the contributing factors? That's really hard to get to, but if we think about it, we have a campus in the state of Missouri that allows alcohol on campus. And they provide alcohol to students that are of age. There's only 2 of the 24 campuses that we work with that allow that. But at some point, we have to have hard conversations with those 2 campuses that they might have higher drinking levels on campus, even of underage students, because of that policy, because that does provide a source, maybe a little bit more than your average campus would have. There's also contributing factors that keep students healthier, like the fact that there aren't a lot of bars or restaurants within walking distance. There isn't a place to buy cannabis. The fact that we maybe don't allow for medical cannabis or recreational cannabis in our state. Those are all contributing factors to why we might have a little bit lower rates of cannabis use on our campus. So when we think about risk and protective factors, and for those of you who have not used the Prevention with Purpose, the strategic planning guide from the DEA, it is awesome. I use it very, very often. It is one of those data sources that I look to the most. I also really like a recent book from David Anderson and Thomas Hall that really looks at sort of where we're at in terms of the future of prevention moving forward, not necessarily post COVID-19, but it does pay homage to that in the work. But I took these straight from Prevention with Purpose. We need to think about the risk factors and protective factors, again, thank you, Margot, that are keeping students either healthier or allowing students maybe to engage in riskier behavior. And so I won't read these to you, and I'm sorry that it's very small font. But essentially, what we know through the data that we have collected nationally is that students experiencing higher levels of stress were more likely to use non-prescription stimulants. We see that also in the state of Missouri. We have a lot of data that notes that the students who have higher levels of stress or experiencing anxiety and depression also have higher levels of co-use or polydrug use. And so the risk factor there is that if we know that we have students that are, saying that they're experiencing high levels of unbearable stress on campus, that it's a substance abuse or substance misuse prevention tactic to help students gain control of their stress and bring stress down. We might think of that as something that is, for the counseling center to work on, or maybe for student activities. But ultimately, the reduction of high levels of stress among our students is a substance misuse prevention activity. There's also risk factors at the interpersonal level, meaning maybe family relationships or the way that students are understanding their integration with other students on campus. So first-year students who perceive high-risk drinking as a norm and think everybody's doing it are going to match their drinking to how much they think everybody else is doing it. And so on a lot of campuses, we need to collect data about what the reality of use is and what the perceived reality is, because oftentimes they will be very, very disparate. And lastly, there are also risk factors for our community. Students who plan to attend college report lower rates of substances, but when they get into college, they have now almost the same or higher rates of substance use than their non-college peers. And why is that? Again, we go back to the few slides ago about experimentation, about access, about the fact that there are industries driven around, the fact that we have bars and restaurants that college students can get to easily. I feel confident that in my town, where my university is located in Columbia, Missouri, that there would not be this 40 or 50 bars or restaurants in downtown Columbia, which is where University of Missouri is located, if there were not 3 colleges within walking distance to the downtown. It would be shoe shops and restaurants and theaters. But because the college students are there, the community has risen up around it. And from a business perspective, those businesses have come in and have been able to make their money off of students. And so there are a lot of risk factors that we have in our environments that we can address through the work that we do. Additionally, there's a great deal of protective factors, things that keep our students maybe from making the choices that are the most risky. We know that involvement in service-based extracurricular activities often leads to lower drinking and substance use among students. When campuses provide involvement opportunities for service learning or for community engagement, voter registration, caring for our community days, et cetera, we often see those campuses, particularly with lower levels of substance abuse and lower levels of violence. Both of those, that community connectedness and involvement in those things often lead to our communities being safer overall. So how do you decide when you look at data? You might be looking at data a lot, but are you looking at the right data? Are you asking the right questions? So when we look at data, we have to ask ourselves about the severity. Is this an issue that is causing a great deal of harm to students? So, and is it causing a great deal of harm now or in the future? So I think about nicotine use. Juuling, especially with EVALI and some of the viruses that have come in COVID-19, does have more of an immediate effect on students particularly. But for the most part, we address tobacco use differently because it doesn't necessarily have risk factors for students immediately. The severity isn't really truly going to come until they're much older after they're lifetime smokers. That causes a bit of a problem when we want to address something right now, is that people might say, let's just wait till that's a problem, or that's not really, we're not in the business of preventing lung cancer among our, 65-year-old alumni right now. We're worried about our students. And so thinking about severity. We also have magnitude. Again, how much is it affecting our campus? Is it enough that when we put interventions into place, that magnitude will be affected? So we have a campus whose meth use rate rose from like 0.25 to 0.5, which is 100% increase in meth use, but it's still 0.5% of its population. And so we have to truly think about magnitude. Now, if we had cannabis use rise from 15% to 30%, that's 100% change. But it also means that we have 1/3 of our college students using cannabis. And so while it's important for us to address all issues, we truly, in order to have that conversation we're going to have in a minute about capacity, we have to think about magnitude and how much we can truly affect the problem, or how big the problem is, and if it's truly affecting our campus. We have to look over time. Certainly, that is part of the reason why I am making the pitch, if you will, to do assessment post-COVID-19. We have to see where we're at and how that's different pre-COVID-19, but also don't let it stop after you do an assessment, say in a few months in the fall or in next spring of your students. Do that again and follow up in a year and see if those things still ring true. We do an annual survey in Missouri Partners in Prevention with our campuses, partially because that's what our funding source asks us to do. But even putting in every 2-year or every 3-year monitoring of the same principles helps give us a time trend to really look at what the severity is. And also comparison. Compare yourselves to national data. If you have access to a statewide coalition data and you can look at like, how do we compare to the state? Our campuses do that a lot. I get campuses that are worked up about a particular issue and they're like, oh my gosh, we have 10% of students engaging in this problematic activity. And when we say to them, well, actually, yes, you do. 1 in 10 students does, but you are the lowest rate in the state. So you must be doing something well to keep that low, because we have campuses where students are engaging in that behavior, where 1 in 3 students are engaging in that behavior, not 1 in 10. So it's important to know comparison, because that can tell us whether or not that particular behavior is low and being kept low, or it's particularly high, and how we might compare. And lastly, we have to think about, and this is moving into the implementation of a data-driven approach and getting ready to build capacity, as we have to think about what practical information we have about data, how practical is it to get something like counseling center data. Because I know on my own campus, that is something that is HIPAA protected. And so there is, no one necessarily on that campus that can put that data together in a way that can not necessarily, that wouldn't violate the students' rights for their medical protection. So therefore, we have to think about, like, is it practical for someone who has access to that data and is a HIPAA compliant person to look at that data, give us information that we need? I apologize. So when we think about evidence, data-driven decision-making, and this will get us to our next task of capacity, is that we have to identify issues and set a base data for baseline assessment. We have to see where we're at and why I am making a pitch for doing some data assessment or doing a survey or pulling data post-COVID-19, or maybe right now while we're in this Omicron surge, is that we can set that data baseline and know where to come, where we're working from. I've had campuses before that have said, I don't think we really want to gather information. But the problem is, if something happens on their campus or they want to gather information later, they're not going to know whether or not that problem has gotten worse over the past 5 years, or if it was always high. They're going to need that baseline data at some point to refer back to. We need to set measurable goals. We need to think about things that the reduction of our binge drinking rate or the reduction of our cannabis use rate by 50% in 1 year might not be something that's actually measurable. And we want to create strategies and tactics that move people forward, that give people the sense that we're making progress. And so by setting measurable goals, you create strategies and tactics that can address the goal that you have that's measurable. And then, like we saw in the SPIF, again, we evaluate our programs and we make our future plan based on assessment. So I'll just stop here and ask if anyone has any questions about assessment. We're going to go through capacity, take a very short break, and then we'll follow up with planning, implementation, evaluation, sustainability, and cultural humility. Any questions at this time? So I want to begin by talking about capacity in this way. If you've never done a capacity assessment, I highly suggest you do one. Basically, it's looking at your resources that you have available, as well as the readiness of the partners you have available to you to address a particular issue. So I've seen this play out on a lot of campuses where an administrator has said, I'm going to put $10,000 towards this. I need you to solve it. But there is nobody that has time to solve it. And there is also no institutional will to solve that problem other than that administrator saying that they're going to put money towards it. That is not a good combination for capacity. Capacity is where your resources and what you have to work with meet the readiness of your partners, which means that what you put in your plan or in your implementation that you're going to do might not solve all the problems you have on campus, but it may solve the problems that you do have the resources and the readiness to address. And so when we think about capacity, one of the major components of capacity is people. And so I'm going to spend a good amount of time talking about building coalitions and talking with others and building partnerships around, kind of going back to that 100 cups of coffee work. So there are four sort of levels of people that we can interact with on prevention. And they go anywhere from collaboration, which is highly involved, the people that we turn to daily to help us with our work in substance misuse prevention or violence prevention, et cetera, to coordination, where we'll do some events together, and I'd be happy to help you with that, to cooperation. We can make sure we're on the same page. Sure, I'll share the same data, and I'd be happy to not contradict you in a meeting, kind of thing. And then there's networking, which is just getting to know each other. Where we want to be is at the collaboration stage, or at least the coordination stage. When we have a coalition or a group of people that's only networking and sharing data, it is not an action team, it's a talking team. And talk sometimes leads to action, but for the most part, it's just networking. And so we have to really think about that. Is the groups of people we bring together, are we networking? Or are we collaborating? Are we seeing what we do as buying into the work of someone else on campus? And of course, we obviously have no involvement, which hopefully we don't necessarily have that on campus, but I know I've had a few partners that have just been like, not my problem, see you later. And we just have to wait, unfortunately, for that person to no longer be on campus. So I'm going to talk a lot about community coalitions, and I'm going to ask you in a minute, just so you're prepped, to tell us a little bit about if you have a coalition on campus, what the strengths of that coalition has been, weaknesses, opportunities, and challenges. But I love this quote because it reminds us that community coalitions in and of themselves are not an evidence-based strategy. You're not going to use a coalition in the SPIF. You're going to find build capacity. You're not going to find use a coalition in the college aim or necessarily even in the SAMHSA evidence-based strategies log, but you are going to find that those interventions are much better when they are evaluated by a collaborative group of partners. So when the services and the plans that we make are based on the most current research and local data, and we then create an infrastructure with our group to support planning and services to address that specific community concern. So in a few words, for those of you who are able to be on chat, if you could tell me a little bit about the strengths, weaknesses, opportunities, or challenges of the coalition work you do, or just we don't have a coalition, we don't have a group working together on substance misuse prevention. That's all helpful to see in the chat. So as you're putting that in there, I want to note that there are 6 elements of successful coalitions. There are other habits of high effective coalitions that I'm going to go through in just a moment. So thank you, Sarah. Sarah noted that there's been a lot of turnover in the group during the pandemics. Absolutely. We've had the great resignation, a lot of people losing their jobs, a lot of people tasked with other people's work. And I think that that does affect coalitions in general. So the 6 elements of successful coalitions are a clear mission and a strategic plan. It does not have to be, I believe that you could write a strategic plan on a napkin if you had to. Strategic plan is simply just the roadmap that you're using, and your coalition is the vehicle in which you're driving. And so you use that clear mission and your strategic plan to move forward. How do you get a strategic plan? You start with assessment and capacity building, and you make a plan in the planning portion of the SPIF. You implement, evaluate, and then you return again to the plan to make changes. Successful coalitions have broad, diverse coalition membership. They don't have people with the same skill sets or the same strengths all in the coalition. We also have strong continuing leadership, whether that's somebody who's a champion, like an administrator, or it is somebody that is willing to be in that role as a coalition leader, whether it be part of their job or as a maybe an additional duty or responsibility of their job to have that continuing leadership. I am not a huge fan of chair people every 6 months or every year. I think that gets kind of confusing, but there can definitely be some shared responsibility of leadership to be able to create that strong continuing leadership. A coalition also has diversified funding sources. It doesn't necessarily rely on just, say, in this case, the substance abuse prevention professional and their budget that the campus gives them to do substance misuse work. It might mean that the budget of, say, the conduct office or the dean of students office is putting a little money in to be able to implement the basics program, or is putting a little bit of money in for the training of their folks on the public health approach. And when we get to training and evaluation, that's incredibly important. They're thinking about training their staff on these coalitions so that they know what the public health approach is, that they know what the strategic prevention framework is that we're using moving forward. Other very basic habits of highly successful coalitions: they meet regularly and they don't cancel meetings. That doesn't mean weekly, but having a monthly meeting and with an understanding that that meeting not be canceled is really, really important. Additionally, having a meeting monthly means that if you do have to cancel a meeting, you're still going to meet again in 1 month. When you have meetings every other month, if you cancel a meeting, you don't meet for 4 months. You're discussing the current issues and events. Again, a talking team is great, but you have to move to action. But you also feel free to talk about things like, rise in crime around campus. You have to be willing to talk about those hard things and come to strategies. It encourages leadership among members and has a record of coalition work. So they share the success stories, whether that be the implementation of a survey or the implementation of an event, and they celebrate that. Recognition is so essential for coalition work because for the most part, these people do not have this in their job description. And so if you're not spending time recognizing them either through a note to their boss or supervisor or some sort of small token of appreciation, as well as just genuine appreciation during the meeting, they're going to not necessarily feel that that's a place that they want to spend their time. Members need to know why they're members, why they're brought there. And if they don't know, that's where the 100 cups of coffee come in. Margot can share in the chat, but we have a community or a coalition toolkit that we developed in PIP, and you're welcome to use it or bookmark it. But there's a piece in that coalition toolkit that gives you questions to ask as you're having those 100 cups of coffee. And it finds out, like I love to ask when a new person comes on campus, so like, tell me a little bit about yourself. At your last campus, were you a member of any substance abuse task force or did you work on substance abuse? What do you think of, like, what have you heard so far about our campus? What are you most concerned about? I love to find out from people what their strengths are and not necessarily what they do in their job, but what they love to do. We have a campus where a person who is like in a faculty role, and you wouldn't necessarily think this of this faculty member, but the faculty member really, really loves to engage with students, like outside of the classroom, not just in the classroom. And so she is someone that they lean on to be their moderator of their peer education organization. But that campus wouldn't have necessarily known that community member or that faculty member had that interest without asking her, like, what are you looking to get out of your job? I love finding out from new staff members what they want their next job to be. So if I meet with a staff member who's a new fraternity and sorority life professional and they say, I'm going to get my, master's or my PhD and I want to be a dean of students one day, I'm going to get them involved in the coalition work that's going to help them be a better dean of students or help them in their master's or their PhD work. I'm going to encourage them to use those skills and to have something more on their resume when they leave. That is how you get buy-in, and members know then why they are members. So let's go a little bit to roadblocks. We're going to talk about identifying these roadblocks and how you kind of get past them. But when you have lack of buy-in, when you have lack of leadership and you don't have a plan, you're not going anywhere. You're literally sitting in the parking lot, not moving the vehicle. And I've been on many of these coalitions or task forces or work groups or whatever you want to call them. The name is different, but the purpose is the same, where people just make a lot of complaints. Well, we don't have access to this. Well, we don't have access to that. We don't have enough money. We don't have enough time. We're tired, etc. As coalition leaders, we have to move the conversation back to what we do have. And maybe it's very small. But post-COVID-19, I think the piece here is even doing an assessment of what did we learn about ourselves during COVID-19? What partnerships do we have? I know there are campuses that have really developed great partnerships with their local health departments that they didn't necessarily have before. And that partnership doesn't have to end when COVID ends, because it could mean that the health department also has access to resources about sexual health. It has access to resources to help students quit nicotine or tobacco. It could mean that there's an opportunity to have training from that health department, et cetera. And so we have to think about what we do have, even if it's small. And so when we don't meet regularly, when we don't have the problems centered around solutions and the strengths that we have, and we don't recognize our work, our coalition will ultimately fail. So while I don't mean to necessarily focus on this for longer than it needs to be, I think we get frustrated a lot, and we think our coalitions maybe we don't want to waste their time. We don't want to hold a meeting because we don't have anything to talk about. That might be more our issue than it is their issue. But the more often we cancel the meeting, the more often we don't encourage that open dialogue and we don't focus on change, the more we're killing our work before we even get started. It's not necessarily that we are wasting those coalition members' time, but we are not focusing on sort of the key aspects that we need to moving forward. So some really focused area things about broad, diverse coalition membership is to create those win-win situations for folks. And I'm going to talk a little bit about developing a win-win. But the value of a cup of coffee or tea or soda or walk around campus, just an individual catch-up meeting to be able to say like, hey, how are you doing? What do you do in your job? Tell me more about yourself. Tell me more about what you want to do moving forward, is going to create relationships with people that you're going to have a sense of who's on your coalition rather than just what their name and their job is at the university. And we have to use some strategic thinking to determine membership. And we, again, need to think beyond Jane Jones, campus activities representative, or Jerome Smith, FSL coordinator. We need to think about the fact that maybe Jane Jones has a background in marketing and would really like to help the coalition with the social media moving forward. Or maybe Jerome is working on his PhD and is interested in learning more about data and would love to be the contact for the survey that you're about to send out. Maybe his job description as the FSL coordinator doesn't necessarily scream assessment professional, but for what he wants to accomplish, that is something that that you can really take advantage of. So finding out from people what motivates them. And you don't necessarily have to do this all at once. I know it seems overwhelming, but over time, this adds up. I used to keep just a little notebook about the coalition that we would work with at the University of Missouri and Columbia. And I would just make notes like, this person has a kid in school, is very interested in what we, outreach that we do to our Columbia public school system. This person getting their PhD needs research experience. So the next time I had a task or a project or something, I could go to those people and I could note that, this might be a win-win for them. They might get the data that they need to finish that or to, start their dissertation, or they might really be excited about the experience they're going to have. So when we think about developing that win-win situation, we have to think about what their benefit is, or what those people's benefit is to creating a coalition driven strategic plan. That means that we think about the specifics of the problem rather than being intimidated by the enormity of the problem. So having folks from fraternity and sorority life, from residence life, from campus police allows us to hear about the problem in a little bit more manageable scenarios rather than just seeing data maybe that is too large for us to comprehend. We have to think about the fact that when we write a plan, we're not just benefiting the substance misuse of our students or addressing the substance misuse of our students. We can be allowing for the win-win of our membership. So maybe our folks in violence prevention are required by the grant that they have to do a certain number of outreach presentations, but they're having trouble doing that post-COVID because students don't really want to gather. Maybe there's something that your coalition as a substance misuse coalition can do to help them address the problems, because substance misuse and violence prevention are inextricably linked, to be able to put that in your strategic plan and help them moving forward. Then they're more likely to help you. So I like to think about the creation of membership of a coalition by the reasons why, and I'm going to focus on alcohol, but you might have a well-being coalition that maybe focuses on cannabis or nicotine or other issues of well-being. But for this, I'm going to focus on a substance abuse coalition that's addressing alcohol. I like to think about the causal factors behind something, to think about what people I need at the table to address that problem. So students' decisions to drink According to the U.S. Department of Education's Higher Education Center, it closed several years ago, but I still use these because I think they're so helpful. The work of the Higher Education Center has now been taken on by our friends at the Ohio State University. They do great work and have a lot of resources related to these things. But campus social norms and expectancies really drive how students drink on campus. If they come on campus and the first thing they get maybe is introduced to a party culture, or their RA lists all the bars to go to when they first come out on campus. Like, you should definitely go to this bar and this bar cards. We like to think it doesn't happen, but it happens all the time. Those are all setting up norms and expectancies for students. And so we have to challenge those by either doing different things in our community, like the first event that students come to on campus is a huge barbecue where alcohol is not involved, and it is between 11 p.m. and 1 p.m. in the morning, which are prime drinking time, which helps them set the expectancy that this is what we do on campus rather than engage in high-risk behavior. Campus policies and procedures make a big impact on how students abuse and use alcohol on campus. So if students believe that the campus is not going to take the alcohol policy seriously, they're going to use more. If they know that they're not allowed to drink in a residence hall and they're going to get in trouble and they're going to be adjudicated and potentially go through basics or some other intervention, they're going to spread that to others, and then they're not going to drink in that location as much. But if the campus police or campus safety or residence life has a just pour it out mentality, they are going to continue to do that behavior, and they're going to pass it along to others that, this campus doesn't care, or my RA doesn't care. The availability of alcohol. How many bars and restaurants, again, are within walking distance to campus? Do we allow alcohol delivery? Now there are a lot of alcohol delivery services due to COVID. Do we allow those to come onto our campus and deliver alcohol to students? Is there a packaged liquor store close by to students? Do they card, etc.? And then there's the enforcement of regulations and laws. Maybe our campus takes alcohol seriously, but the community law enforcement agency does not. They don't take it seriously at all. Or maybe the local justice system, judicial system, does not enforce any sort of MIP or minor in possession by consumption laws. They just throw the ticket out and plead it down to a traffic ticket. Those are all going to be ways in which students get the idea of whether or not they can engage in high-risk behavior with, again, it's a risk and reward type of mentality in the adolescent brain. Also, the availability of alcohol-free social and recreational options. And it doesn't matter where the campus is. It could be in downtown St. Louis or Kansas City or in the middle of nowhere, Missouri. Students always say there is not enough fun things to do on campus or in the community. And so do students feel like they have options to drinking? So therefore, when we take these, sorry, I've got some kind of weird, I'm sorry. So when we take these people and we think about like all the people we might have on campus to be in our coalition, I like to assign these folks, or think about it in my brain and assign these folks to the different risk factors or the reasons why students drink. Our chief student affairs officer should definitely be in the conversation about policies and laws. Our student activities folks should be in the conversation because they can help us with the alcohol-free events that should be available on campus. Our business owners and property managers are our city employees that license alcohol retailers. They are in the conversation about the availability of alcohol. So when we think about who do we need to have in our coalition, it's not so much checking boxes of people as it is thinking about the reasons why students engage in that particular behavior, whether it be cannabis use. Maybe you say that, cannabis use, students don't know that it's a problem. Well, why don't they know it's not a problem? Well, maybe we don't do any cannabis education for incoming freshmen. So then your people that you would invite to the coalition and into that work are the folks in orientation, are the folks in the deans of students office, the people that set that, maybe that curriculum for incoming students or a first year experience course. I have a few slides here that I think are really helpful. Our colleague in Missouri Partners in Prevention, Molly Linder, couldn't be here today, but she is part of the City Substance Abuse Advisory Commission in the City of Columbia. And this is an excellent way to sort of look at how we can bring people that are from different backgrounds together to a set of purpose and objectives to address the most risky problems of, in this case, youth and substance use in the City of Columbia. So the Substance Abuse Advisory Commission, because it is made up of folks from higher education, K-12 education, folks from public safety and law enforcement, has put together a lot of recommendations, not always that are implemented, much to Molly's chagrin, I'm sure. But they have had ordinances that they have been able to weigh in on. They were able to weigh in on the to-go alcohol legislation that happened in our community. They were able to make recommendations for the citywide use or availability of Narcan to prevent opioid related deaths. And so they were highly instrumental in getting the server certificate in the City of Columbia, which meant that folks had to attend a server or seller alcohol training, such as our statewide training called SMART, in order to be a server or seller of alcohol in the City of Columbia. That was something that a local community organization could such as the Substance Abuse Advisory Commission could recommend and move forward in our city government. So, but I think what's important is to think about some of these things, in terms of what intersectional activities or initiatives that we can do, where we can bring in folks from our different coalitions to serve on each other's coalitions. We can have a bar owner meeting, or maybe there's no bar owners on our city Substance Abuse Advisory Commission or our local coalition, but maybe we ask them to come together and we share our perspective on alcohol accessibility in our town and ask them what they need for training in order to address that. So this is the slide that I was mentioning in terms of creating that coalition of key players. These are the people that I would associate with each of those five sort of aspects of why students drink on campus. And when we create win-wins for campus, or for our campus partners and our community partners, we must have a win-win mentality for every single person that we work with. What are they going to get out of it, and what are we going to get out of it by partnering? The coalitions that I've seen that have brought people together and said, we are all here in service of the goal of this piece of paper that is our strategic plan, never get anywhere. But when there is when we have built relationships with each other in those coalitions where we are finding out what matters to both the individuals, but also the offices or the parts of our working campus that they represent, we are determining sort of the best way to move forward that meets everyone's needs. I think that if there is not compromise in substance misuse prevention, we're probably missing the mark. There are certain things that we're not going to want to compromise, and we need to determine that. As a substance abuse or misuse prevention professional, I have certain truths that I hold deeply. I believe strongly in really not debating the 21 age alcohol age purchase. I believe that we do certainly have students that are under the age of 21, but if I was running a coalition, I would say, absolutely not. Are we going to sit here and debate whether or not we want to change the legal drinking age? Because first of all, it's not going to happen on our campus. It's not going to happen in our community. And there are certain things that we're going to spin our wheels if we debate that. I also believe strongly as a professional that cannabis and medicinal cannabis can be helpful to some people, but many people in our communities misuse cannabis in the name of saying that it's medicine. And so I will never stop advocating for the fact that we need to think about cannabis and the way that folks use cannabis, all forms, a little bit differently than just assuming that, it is it's not harmful, because it's definitely been harmful to our students on campus in terms of their academic work. So if I was running a coalition and somebody said, I think we should make cannabis, freely used on campus, and, I think we should invite the head shop on campus to have, teach students how to use safely. That would be something in a coalition leader that I probably wouldn't allow, because that kind of flies in the face of the things that I have determined are my truths. I would love to have a conversation with that person on my coalition that might want to do that, but I'd also talk to them about things like the Safe and Drug-Free Campuses Act and why we can't have campus use of cannabis and things like that. And we have to also think, like, what's in it for you, and what potential coalition members have. There are some people strictly on coalitions because they are in the circles of people that have money and credibility and power and clout. And that is okay. Sometimes we might not bring somebody on our coalition because they're going to do a ton of work, but they're going to give us access to people who can do work for us. We certainly want people with passion and creativity and experience, but you're looking for these things when you're more or less not really interviewing people for our coalitions, but you're thinking about how to create a coalition structure moving forward. So there's a lot of different ways in which our coalition members think about readiness, and have readiness to move forward. And these are examples of people that are not quite ready to move forward. So when we think about, again, capacity is readiness meets resources, we're listening for our spidey senses for us to hear things like, I don't think anything will ever change, or I kind of like things the way they are. I don't really want to rock the boat on that policy, or it's not, if it ain't broke, maybe we shouldn't fix it. That doesn't necessarily scream readiness for your coalition. You want to be listening for those things. It doesn't mean that it's not changeable, but it does mean that potentially we need to think about how we might work with that coalition member a little bit differently. But there are ways to increase readiness. There is involving people in making the plans. It's kind of a mantra of mine that those who implement the plans must help make the plans. We cannot create a plan for someone and say, do it, without asking them to assist us in the creation of the plan. We must be flexible and be willing to listen to ideas. We must be willing to give up something and compromise, and most definitely reward, whether that's by providing food at every meeting, providing a polo shirt to wear on campus, or a nice piece of swag, finding out from people what is their method. I love to ask my staff and our coalition members, like, what is your preferred form of recognition? For some people, it's like, do never, ever say good job to me in front of a group of people. That embarrasses me. I don't like it. But if you write me a handwritten note and tell me that I did a good job, or you tell my boss that means the world to me. We need to think about reward and recognition as a key piece to capacity building. And then lastly, the way we develop capacity and of people, as well as really the work we have moving forward, is to train our coalition members, is to find out what training they need, is to do an overview maybe of the public health approach. This is going to be very, very important post-COVID. There are going to be new people. I think somebody said in the chat earlier, there are a lot of people that are new to higher education prevention. There's been a lot of turnover. So thinking about first assessment as well as capacity building and what training we need to do to move people forward is really important. So before we move on to our last piece, I want to ask if there's any questions, and then we'll take about a 2-minute just resource break, and then we'll come back and finish up our slides. Any questions at this point? Okay. I will continue to watch the chat. If there are questions, feel free to chat at me directly if I'm not quite hitting the nail on the head for you. And we will come back in about 2 minutes, or two or 3 minutes. I'm on Central Time, so 2:30 Central Time, and resume the rest of the slides. We're on a break right now, so maybe that's why you don't have sound. Go ahead and resume. I know there might be people coming back at different times, but we're going to move on to planning. We're going to go pretty quickly between planning, implementation, evaluation, and then talking about sustainability and cultural competence so that we can wrap up at time. Again, feel free to put any questions in the chat, and we'll go from there. So a big part of planning when we're in the planning phase of our strategic prevention framework is to prioritize the items that we found in our assessment with importance and changeability. So this is where especially with changeability, that's where capacity comes in. And so we want to be able to answer the question that, like, how does the resources that we have, how will they impact the problem that we're seeing, and how much can it change? We might have a lot of people willing to work, but $0. And so that might mean that there is something that we want to be able to make an effect on that has importance, but it doesn't really have changeability because we can't make that, true full effect. We also could have a lot of resources and a lot of capacity to address something that really doesn't have that much importance, that it definitely would make a difference for maybe 0.5% of our student population, but overall, it's not truly affecting the health outcomes of our students. And so we need to select prevention interventions from the available resources that we have to develop that comprehensive data-driven plan. So the way that we do that is by using the socio-ecological model. If you are not familiar with the socio-ecological model, I can certainly back up and do a little bit more of a 101, but basically it means that an individual, in this case, a college student, doesn't make decisions in a vacuum, that they are influenced by their peers, the organization of which they are a part of, as well as their community. And so if we look at the socio-ecological model on the left, we see students as a small part, but the students overall are making decisions maybe based on how their peers are interacting with them, what expectations their campus sets for them, or the things in the environment that maybe encourage high-risk drinking. I think about some alumni type events and homecomings and things that are, again, rooted in some pretty risky behavior. The student might not want to drink, but it's kind of what's in front of them. Might not want to use cannabis, but there is a pretty, hefty celebration of, the smoking day of cannabis in April every year that a group of students do on campus. So it's just around, and it is part of the culture. But they're also influenced by their state, maybe their territory or native community, as well as their city and county, which means that, the laws and the policies of that city and county. So again, we go back to the reasons why students drink, and we think about the people that we have in our coalitions, the capacity that we've built, and then we have to select strategies that address the problem at every single part of the socio-ecological model. So again, the things that have importance and changeability, as well as comprehensive nature. So for the individual, we might implement things like basics. For those of you unfamiliar with basics, it's brief alcohol screening and intervention for college students. I highly recommend, if you haven't visited the AIM, the college AIM, the college alcohol intervention matrix, it's very helpful for you to be able to pick strategies at the individual, organization, or community level to help affect change. And it tells you about how expensive that intervention can be, what it means to implement with fidelity, et cetera. It's just a really, really great resource. It's from the NIAAA. Additionally, some things we can do from the peer level, we can do social norms interventions. If you're not familiar with social norms, the National Social Norms Resource Center at the University of Michigan does a great job at giving that information. Bystander intervention or bystander engagement really focuses on the peers of which these students who are making their individual choices and how they interact. Peer education, again, focuses on the peer component of the work. But then if we only are focusing on the individual and the peer, we're missing out on really some major factors for how students use their or how students are engaged with their work. So from an organizational level, if we are not adopting a policy or enforcement, we're not including substance-free work on campus and maybe supporting students in recovery, having alcohol-free events, we're truly not supporting the work that we're doing on the individual and the peer level. If our community is not limiting access to high levels of alcohol or access to alcohol by minors, they are contributing to the problem. And so I often talked about this when I was a health educator and a peer educator myself, is that I could give a fantastic presentation where the students think, yeah, I'm going to totally drink moderately next time. I'm good. Thank you so much for this information. But if they go out to the bar with their friends and it's cheaper to get a beer than it is to get a soda, they're going to make the choice that's cheaper and probably more risky. And so we have to think about, again, how the environment really affects our students and then design our individual strategies in our plan based on that. So we have, again, different theoretical approaches that help address things at each of those levels of the socio-ecological model. Our environmental level strategies address the community and the college and university, and the individual level strategies that we have address the smaller communities, the peers, and the students themselves. So the 5 main strategies for environmental management that are going to be very important post-COVID are thinking about alcohol-free options. So more and more students are choosing not to use alcohol than ever before, and COVID might have exacerbated some of that. Students maybe are looking to make a change post-COVID. And so if we don't have alcohol-free options on campus, if we aren't letting students know what their options are to live a substance-free life, we are definitely missing out on a contribution we can make to our campus. We have to change the normative environment by doing things like talking about our social norms, the fact that most students might drink, but most students, when they drink, have 1 or 2 drinks. They don't have 5 or 6, which would get them to the level of intoxication. Most students on campus choose not to drink and drive. Most students would help a friend if they had alcohol poisoning. Those are all things that change the way we think about our normative environment. We also should limit alcohol availability, thinking about, again, how many bars and restaurants are in the local area of a campus, thinking about the drink specials and promotions that are provided. There were a lot of drink specials and promotions when we were kind of having our first downslide after COVID about a year ago that were really focused on, like, we've kind of got past COVID, come and drink free as much as you want. I still am in a community or work in a community that has specials like ladies nights and drink free until you pee and flip cup and other things like that, that really encourage people to use more than they probably would have thought of using when they first engaged in that environment. So again, I've talked a lot about the college intervention matrix, and it is really a very useful document that we need to use in our planning phase. If we are not looking at the aim and considering that to be something that we interact with daily or even weekly in our role in substance abuse prevention, we should be. Their matrices, they have a lot of words on them, but I have printed them off. I have a copy at my desk here in my home office of the strategic prevention framework, the public health model, the SEM, and the alcohol intervention matrix, because it helps me remember what it is that I need to be sort of grounding myself in as a substance abuse prevention specialist. So then when we implement, we need to, again, think about implementing those strategies that we've selected in planning that address the important issues or the issues that can have the most opportunity to impact the community, as well as the changeable aspects on campus. So we're going to ask ourselves, for our interventions as we're going through, a big part of implementation is planning for evaluation. We're going to implement and ask ourselves, was this intervention effective? Will the intervention that we're selecting in our planning process impact the selected risk factor? And is the intervention that we selected, is it feasible for our campus? Is it something that we want to see done on our campus, or is it something that there's no readiness for? And when we look at something that is effective, conceptually fits with what our problems are, and practically fits with the people and the money that we have, again, going back to assessing what the problem is, determining our capacity, planning and selecting those effective and conceptual fit strategies, and then going back to our readiness conversation and thinking about, is this practical based on what we have? That is how you're going to find your best fit for the interventions that you select. Again, I know this is a very lengthy process that I'm describing, but it really does get you to better outcomes overall when you're selecting the things that are going to be the best fit for your community. So when we put a plan into action, we have mobilized our support and we've built capacity and we've carried out our interventions. And then we're going to create process and outcome evaluation. So that's part of thinking about some long-term strategies and like what we hope to accomplish long-term as well as short-term. And we'll talk about those here in a minute. And then we're going to monitor throughout our implementation, evaluate, and adjust. So when we evaluate, we're going to think about examining the process and outcomes for the intervention. So again, not just did we decrease the binge drinking rate among our students by 10% in 5 years, but what things did we accomplish in the short term? So you're really asking yourself, is my plan succeeding? And are you measuring success throughout? I don't love the idea of like counting smiles, like, oh, people really like this intervention. They looked very happy. But that is a process evaluation, that you had a good response to implementing alcohol skills training program, that students seem to like the training. But then we're going to also need to look at some long-term measurement to see if that really made a difference. So process evaluations document the implementation of the program or intervention. So like the number of presentations that you gave, the number of students that attended, again, the overall number of partners that you brought in. Those are going to be your short-term outcomes, and they're going to be the process evaluation that you do. A lot of people think that they can't really evaluate, or they need a paper, a survey to evaluate any effectiveness. Absolutely not. You start evaluating the moment you just start counting the work that you do. And so start thinking about that. How will you measure how this is succeeding? And it just starts with how much you're doing or what you're doing, how many meetings you've had, how much conversation you had about a particular topic. Where our outcome evaluations are going to be the extent to which something increased, decreased, changed over time. And those are tied mostly to long-term outcomes. I'm going to move pretty quickly through, I moved through the 5 steps. Does anybody have any questions about SPIF in general before I talk about the 2 sort of main components of SPIF, which are cultural humility and sustainability? So the moving forward post-COVID, I think it is really key for us to think about moving forward with a culturally humble lens. And Margot spent just such a good amount of time, and she did a great job talking with us about how we think about subpopulations, how we think about intersectional identities, underserved populations as we move forward. And the 5 ways I know to explain moving forward with a culturally humble lens are to think about assessing, building, incorporating, implementing, and evaluating. And they go along with the 5 elements of the SPIF itself. that when you're assessing, you should be continually assessing the organizational diversity of the work that you do. Do you have the right people at the table? Do you have the voices of people that you are building the work that you're doing for on your coalition? Are you keeping in mind the behaviors of students from intersectional identities or from subpopulations or underserved groups? When you build the capacity for cultural competency, you train your membership. So I spent a lot of time talking about identifying the people on your campus who will be your partners moving forward. So what is your capacity to help them understand what cultural competency is and why we need to address this? Maybe you show them some slides that are, or identify some things that you learned from Margot's program earlier, but you really pull out for your folks the need to think about the fact that we are not just addressing students as one big chunk of students. These students are experiencing these behaviors in a lot of different ways. They come to campus with a lot of different backgrounds, and we need to move forward with that lens. We need to incorporate culture and diversity in our strategic planning. We need to think about the implementation that we have, where we're using culture and the background of culture as a resource in the work that we do. And we have to evaluate our cultural competence or our cultural community if we're, cultural humility. If we are not doing that in our evaluations or in our assessment, we are missing out and really doing students a disservice. So I think the question really that then comes to light as we wrap up our conversation about the SPIF is this even possible right now, especially post-COVID? And most importantly, is this sustainable? I have said this to multiple people. I am tired of planning things that I have to cancel. I am tired of the word pivoting. One more person tells me to pivot, but I think that it's important for us to evaluate our sustainability from the very beginning. Don't start a planning process to look at your substance misuse on campus unless you're ready to make it sustainable or ready to, really do the work of the SPIF. If we don't engage in each area of the SPIF, if we kind of gloss over capacity building, or if we're like, I've got some evaluation, I don't need to do that, we will lose the ability to create a sustainable plan. So if we fail to assess, we're not going to be able to set any outcomes. Your assessment is going to drive what long-term outcomes, what process short-term outcomes you're going to have and you're going to want to see. If you fail to build that capacity, if you fail to look at your resources plus your readiness, you fail to have a coalition or a planning team, you'll be unable to build sustainable relationships that last beyond that single colleague or partner. It's great to have partnerships on campus, but when that one person leaves, a capacity-driven plan or a coalition-driven plan really allows us to identify that the things on our campus that we want to carry forward, no matter who is in this work. We want things to last beyond us and move forward in a more sustainable way. If we fail to plan for our implementation and really think through, how is this going to look? What happens if we have to move this virtually, et cetera? We might get moved off course. Additionally, I know a lot of campuses have gotten moved off course pretty easily by fads. They hear about things like students engaging, like the bath salts use several years ago. We had campuses that went way down the rabbit hole of addressing bath salts and forgot about the fact that while they did have students certainly that were using that, it was a very small portion of the campus, but they had students in the ER with alcohol overdose every single weekend. And so we could get veered off course pretty quickly if we don't plan to have an implementation plan and follow that implementation plan throughout. And if we fail to plan and select evidence-based interventions that match our assessment findings and our capacity, we're going to cause harm. So if we are doing things like that maybe others want to do on campus because they're not very familiar with public health and the public health approach, and they want to do things like a rect car display or a docudrama or use beer goggles. Those are all things within our best practices write-ups that we know not only don't work, but they cause harm to students potentially. And so that is the basis of the coalition leader, being able to have that plan to say that we're not going to get veered off course. We're going to develop things that work for us, but we're not going to implement things that might be harmful to our community. And then if we just truly fail to implement and evaluate, we've wasted all the work we've done to build capacity, and we're going to frustrate our colleagues and partners. So I know it's very tempting sometimes to get bogged down in the details, but sometimes we have to ready, aim, fire. We can't ready, aim, and get, again, veered off course and never actually do the thing that we're scared to do. Maybe it will fail, and that's okay, but we're going to have the assessment to tell us why that failed or what we needed to do differently the next time. And then that's going to start our process all over again. I just want to note, this is my last slide for today's presentation. Again, I know that we didn't necessarily solve any major like COVID-19 related problems, but our goal in this session really was twofold, was to give you some background about how things might have changed during COVID-19 and how the dual pandemics really were affecting our students and have been affecting our students. And then note that we must, because of those two kind of critical things that we've learned, that students are different, our communities are different, the way we have to approach our work is different, that we must not just pick up our plan from 2019 or 2020 and move forward. Chances are some of the people that built that plan aren't even still around working on our campuses, but also we must look at this in a really strategic, evidence-based way. So I'm happy to answer any questions. I know we haven't had a ton of questions in the chat, but you're welcome to reach out to any of us at Missouri PIP. Our email is just pip@missouri.edu. Margot and Kaylee and I will be around to answer any questions after this session, but we thank you very much, and we'll turn things back over to Orlando.
Thank you, Joan. And while we wait for questions, I would just want to remind everyone that certificates will be sent out in 7 to 10 business days, and that if you need CHES credit, please make sure I have your CHES number.
Thank you all for joining us. I appreciate it. Orlando, I don't see any questions in the chat. Have you gotten anything directly to you? Oh. Are you finding on your campus more pushback since the students have returned? Amy, can you say any more about that pushback from students or faculty and staff, administrators? From both. I think that what we're just struggling with right now is a great deal of burnout in higher education. I think that COVID-19 really has shown a light on some of the inequities and the kind of poor planning of higher education, just in general, and this is globally, to address something like the COVID-19 pandemic, the dual pandemic that Margot talked about. And so I just think people are tired. I don't know that, so I've kind of see things in two different ways. First of all, what the pandemic has really shown us is that there are a lot of people that are skeptical of public health, and there are a lot of people that believe strongly in public health. So we have a great divide in our country about what people are willing to listen to. And so I think on some of our campuses, they're going to have some pushback just because now it's kind of okay to rage against public health, because we've seen that kind of nationally and even globally. I also would say that in many ways, for some campuses, um, it's made campuses more focused on addressing these issues. There are partners that are finally realizing that the substance abuse prevention coordinator has had a hard job this whole time because they've been thrust into some of that work, or they've been doing some public health work that they didn't necessarily sign up in their career to do. And so, it's just a very strange time. I think that it'll be interesting to see where we're at in a year or 2 years about how people feel about public health approaches and moving forward together. But I do know that people want to prevent, for the most part, another pandemic. And so if we can think about it in that way, not that substance misuse is pandemic, but it is endemic, and it is something that, my colleague Ellen Gold from Michigan always used to say that substance abuse is something that enrolls every semester and never graduates. And so, I think there are people that are realizing that maybe we should have been doing more all along for a variety of health issues. But I also think they're so tired right now. I think we thought we would be in a totally different place coming back from this semester, because we were in a fairly good place at the end of last semester for the most part, but it's just not the case. So I think time will tell. Thank you for that
Right.
question.
Can you hear me?
Yeah.
Okay. The reason I'm asking that is I used to work at UC.
Uh-huh.
And so I worked with a thing off of public safety. I also was a paramedic firefighter for many, many years. And my degree is in public health education.
Mm-hmm. That's awesome. That's a great background.
So the biggest thing I see through all my careers is public health has taken such a strong beating.
Mm-hmm.
And on our campus, we saw students, of course, we get pushed back because like we have all the events now are massive public.
Mm-hmm.
But we don't have events going on like the Ragers at the sororities and the fraternities and stuff.
Mm-hmm.
We're lucky, our campus, our students, we have an extremely high on our and we actually our university is actually being sued as a class action suit again from students saying that they have no right to ask for vaccination or to suspend them, because that was what was going to happen at the beginning of this semester, prior to the big Omicron thing happening, was that if they were not vaccinated, they were going to be suspended until they could prove vaccination, or they have to do straight online. And there was they actually did a class action suit against them, and our powers to be, I don't know, prior to it or after they were done with it, was that they were giving them to the end of this semester to have that. And so we really kind of see this big, I'll put my video on so like I can see you too. Yeah, there we go. I look horrible. Excuse me.
You're fine. I have the dog barking. It's all good.
I know. Trust me. I'm surprised my cat isn't actually. I don't look bald. My cat isn't up here. One of the weird things that she never gets up when I actually am on video. Any other time, she's like, wah. But so we see that a lot. I live in Dayton, Ohio. If you know anything about the thing, we were literally the OD of the country.
Yeah, right. Yeah.
So we kind of saw I saw things from very differently from the opiate pandemic in the 2005, where people say we didn't have one. I said we did. It was just low income to now middle class to upper, which now people are upset about. And we do get that in. And the reason I was asking about the marijuana or the cannabis is, as you said, I'm older. And I have kids, oh, you can't, it doesn't affect your brain. I'm like, I'm sorry. I went to school in the 70s.
Mm-hmm.
Trust me.
Mm-hmm.
It hurts. And there are bad things. And we do see it from the paramedic and
Right.
different things. Right. And my students like, oh, it's safe. It doesn't hurt. It's better than smoking. It's better than alcohol, and it's better than smoking because it's all natural.
Natural. Yes.
Natural. Yes. My head so hurts. And we cannot get them, no matter what we talk about or what we do, that campaign, those lobbyists to push legalized marijuana and cannabis and all these different things. Colorado was a great one because beforehand you could not OD on cannabis. I'm sure you've heard that. And then Colorado found out that when they did the edibles, children were actually in the hospital OD'd on cannabis oils and different things like that.
Sure.
And there's really no treatment for it. So my biggest issue is like, how do you really try to fight this campaign where these kids grew up with people saying, oh, use marijuana instead of tobacco because it's better for you. It's like you're putting smoke in your lungs, period.
Yep.
You can't get addicted to cannabis. It's non-addicting. It doesn't affect your brain. They do all these things, and it's like, no, cannabis, it impairs your ability to make decisions for over 3 days. I don't know if they did a big study with pilots saying, is it better for them to smoke than drink? And they found out, well, alcohol is out of your system in 8 hours. Cannabis stays in it for over 3 days. And these pilots were making, in simulators, were making deadly decisions 3 days later. And you try to tell these kids this, and I was like, age, and they're like, oh no, it's all this stuff. I said, these people are pushing an agenda.
Right.
How do you find fighting that to be really this stuff? And I do agree, medical marijuana really does seizures. Anxiety can be iffy, just depending on the person.
Right. Yeah.
But pain, marijuana, I mean, it really does have some really strong, good medical with it. So how do you do that?
A couple of things that first of all, my colleague Margot, who's on here, she recently did a presentation at NASPA, a national conference, about the fact that some of our data in Missouri is noting that it is our students that are experiencing suicidality are heavier users of marijuana or cannabis than non-users. There's a link between, so like having the data on your own campus about how marijuana has affected individuals, like asking them questions. I think it's great to have like an alcohol and drug abuse survey, but if you also don't ask about suicidality or about experience of violence, about, whether or not they're getting enough sleep, things like that, you can't then cross-reference and see if there's any difference between marijuana users and non-marijuana users. Again, I send you to Jason Kilmer, and if you Google him at all, it's Kilmer. He does some terrific work, and he's been presenting a lot just about the difference in the THC content of the marijuana that's used now versus the marijuana that was used 20 years ago. So Margot's putting some stuff into the chat that might be helpful for you.
I know I've been like collapsing it. I've been taking pictures.
Yeah, you're good. So there has been a lot of like Jason has talked a lot about the fact that students don't know that cannabis withdrawal is a thing. And so, if there is someone on campus that is a trusted person that, students would listen to be able to get trained on explaining that like the cannabis, you can withdraw from cannabis, you can have these experiences, that there's a reason why that you have to get a medical card for marijuana, because even though like, at least in my state, it's kind of fake and you don't really see a doctor and, things like that. The intent behind it truly is that, I mean, we've had physicians that have explained the process of like, if I went in and said I needed it versus Margot went in and said she needed it, why he might not give it to me, but he might give it to Margot. And so having students understand that, truly and true medical marijuana isn't necessarily smoked cannabis. It is, it's in pill form. And so, I don't know that I don't really have great answers other than just to say that I think there are pieces in this iChamp program that was developed by the University of Washington, that is sort of like a motivational interviewing, personalized feedback intervention on cannabis use. So it really kind of challenges students' beliefs about cannabis, challenges their and not challenges in like a bad way, but talks through students' cannabis use and things like that. So I don't know if that's helpful at all, but Margot put a lot of the things in, and you're welcome to always reach out to Missouri PIP. So
I've been loving. The other thing is, I was wondering, because like I said, where I live, OD city, and the biggest one of the issues we have with Cincinnati and Dayton, Ohio, is fentanyl.
Yes.
And we've had a lot of marijuana overdoses.
Yeah.
Because they'd mixed the fentanyl in with the marijuana. And
very unintentionally too. Like the student hasn't really done the mixing.
That problem there as much as, I mean, I know we're like stratosphere off the chart with a lot of our stuff, but is that something you're finding more and more on campus with you guys, or?
So we haven't, so first of all, I think that the DEA has a really great set of resources called One Pill Can Kill. It's kind of scare tactic-y, but it's actually, this is pretty scary stuff. So I don't have a problem using the scare tactics. But also, we have seen mostly through our like the communities that surround campuses, that's where the ODing has occurred, but it's family members of college students. And so it's, people that a death of a family member is going to affect that student, that's going to be trauma, et cetera. Additionally, I think that the, talking about like carrying Narcan on campus, not because people intentionally use opiates, but because opiates can be laced with different things. It's really challenged administrators, but it's been good because then if students are trained in it, if they are out in the community, and then they're maybe looking at things. I think the DEA told us the other day, we were on a session with them, that it's like 1 in 6 pills that are created on the black market has some amount of laced fentanyl, which is just so incredibly scary. So if anyone buys like 10 pills, chances are 1 at least could be deadly for them.
Right.
So, really kind of explaining that. And I think that is a way to get students potentially to think twice about their black market marijuana use, is that if they truly do feel like they need to use cannabis, they can talk to their doctor, or they can make that request, but getting it off the black market is not going to be safe for them, because they could have this, they could be laced with fentanyl.
I know, like as a paramedic, one of our biggest has been with fentanyl being on the scene. They're like, "Well, Narcan," and it's like the average dose of Narcan needed to normally treat fentanyl that we're bringing kids in, it's anywhere from 24 to 30 milligrams, and a medic keeps 2 to 4.
Right.
We're not even closely. There we go. Yep, the cat. No, trust me. Like I said, I'm surprised mine isn't. This is one thing he doesn't bother at all with. If I'm on the computer, he's on it. But when I'm video chatting,
nope,
never. But trying to get them to understand that dealing with fentanyl, this doesn't even make what we carry, our dosage doesn't even make
Yeah.
a dent.
Well, and
And it
a lot of our
literally,
law
we were saying
enforcement.
anywhere from 24 to 30 milligrams is needed
Mhm.
right now. And
Well,
it's just so hard
mhm,
to combat a perception
mhm.
as opposed to fact.
Right, right. Well, because I think perception is reality for a lot of people, like, and
Yeah,
again, you go back to that, oh, you told me this on COVID-19 and now you're changing it to that, because as we learn more, we do more and we do better. I think it's also true about things like cannabis. It's true about fentanyl and
oh yeah,
opiates. Like we do our best with what we can, but we're doing that spiff, right? We're assessing and then we're going back and
right.
we're
We're
changing
assessing,
our
doing,
plan.
changing.
Right. Yeah. Like no plan, no public health plan ever from beginning to end does not change. And it's not like you just done at the end. You're going back and you're assessing for what you need to do the next time. But
Right.
that's just not a concept that people like the average person, if you will, truly understands, or even the average, person on campus. So thank you. That's a good point.
Yeah. Well, I thank you so much. I
No problem.
appreciate this. I've been so happy I was able to jump onto this
Good.
series because a lot of good information, a lot of good stuff. Campuses are hard. It's a
Yes.
flux thing, like you said, so many different perceptions, so many different cultures coming in, so many different aspects.
Mm-hmm.
Um, what is the college? Because that's what our college opened up for. I'm not sure if they even used this term with your college. I don't know if you shut down with COVID or not.
Mm-hmm. Yeah.
Um, but ours did, and a lot of ours in Ohio did. Our governor
Yeah.
said,
Right.
but it was they wanted to open up for students to have the college experience.
Mm-hmm.
And what the reality or the perception, as you said, what
What
is
the
the
college
college
experience, right.
experience
Right.
and what they
Right.
perceive it as if they just watch movies. And
Mm-hmm.
I mean,
But what
I
a
don't know
great
about Missouri, but
opportunity to,
Ohio has some of the top 10 party
right.
schools
Yeah. Yeah.
and
Well, and
have been since. And the schools are the same that when I was a teenager thinking
mhm,
about it.
right. Right. Right.
So if I thought of if I was going to go to Ohio University, not the Ohio State, but Ohio
Mm-hmm.
OU, that is a hard, since the 70s, probably before that, that is a party school. It's made the top 10 party list all the time. So if
Mm-hmm.
I go to OU, my perception is
Right.
I'm going to party.
Mm-hmm.
If I go to William and Mary, which is a Baptist little
Mm-hmm.
college, I'm probably not thinking I'm going to have a really strong party
Mm-hmm. Yeah.
thing with that. So, I mean, and I understand what schools you go to what the perception of the school
Mm-hmm.
is, which is then you go
Yeah.
back into is that what is that? And that's what our provost actually was using the words. The students can have their college experience.
Experience. Right. But
And
that's an
it's like,
opportunity missed to not define that. Like, we want you to have the college experience. We want you to live in a residence hall. We want you to interact with your faculty. We want you to study with friends. Like, they could define it and set the norms about what the college experience is. But when they say the college experience, it's just like if you say to me, like, best dessert, I have like 5 different things that I can think of are the best dessert. But if you say dessert like chocolate chip cookies, that might not be what I'm thinking of. But if you leave it open-ended, it doesn't quite, and it again goes back to the norms, et cetera, that we talked
mhm.
about. So, well, thank you so much for
And are you
joining. I
having
appreciate
more
it.
issues with trying to change that perception of public health right now? Because I mean, I know across
Mhm.
the country, our public health is,
Yeah.
I mean, it's just bad. Ohio, our people
Mhm.
got just
Yeah.
dead slammed.
Hmm.
And so it is a very, very highly mistrust
Right.
right now. And I don't know, as a public health person, is how much we truly can build back up
Hmm.
that trust right now.
Yeah. I was talking to somebody the other day that substance misuse prevention is 100% a public health intervention, but nobody needs to know that. They can just call it substance abuse misuse prevention or substance misuse prevention. Like before, I think we gained favor by calling it public health, but now it depends on, who you're talking to, right? Like, so I do think I think there's a key element to leaving out the public health part with certain people and just calling it, what it is. With others, they saw that public health saved lives. And so they feel good about it. So.
Right. Okay. Well, thank you so much. I appreciate
you
talking and doing the stuff. I was really trying to take your idea on some of these things because campuses are campuses, but there's like our campus is outside of downtown Cincinnati. We're not in a good area. We've never been in a good area. So we have a very different cultural aspect of it. And so I was kind of like, okay, I know where you're kind of at. I know your stuff. Are you seeing things? Because really where you live in the country, where you do, how you perceive things, what they're going on is very much. And my daughter, she works at Ball State in Indiana. And when I look through some of the stuff, one of the highest crime rates there is B&Es. And they attribute it to, as a college town, there are very little things for these college students to do. So they're bored. And we all know, and this, please don't take this the wrong way. We know when kids get bored, they can become destructive. And I hated saying kids with the thing because they're young adults. They really are. But like you're right, mentally. Sometimes it goes that way. So they become destructive. And when they become destructive, bad things happen. So, well, I appreciate it. Thank you so much.
No problem. Thank you. Good to meet you, Amy.
You have a great week.
Yeah, no problem.
And hopefully you get to stay warm because we're in a freeze right here and you guys have to be, woo.
Yeah. All right. Thank you so much. Thank you, Orlando, for hosting this through iHack. We will talk to you all later.
Thank you.
Bye.